Dear students, welcome to this virtual 319 lecture. This is week 12 and I'm going to talk about an assortment of mesenchymal tumors of neural origin, of tumors and other conditions affecting the meninges, and of some primary astrocytic neoplasms. So it's going to be quite a collection of different things. As usual, I suggest you to check out the companion lecture that you can get to this, where I have a lot of clinical information, theoretical information and pictures, both gross and microscopic, that should help you understand a bit more. In this lecture I'm going to concentrate on the morphology as usual, with very little theory. And my usual disclaimer, these are the teaching slides, not the examination slides, so please watch the lecture with the examination slides if you're interested in that. Let's start with Pheochromocytoma. This is a rather rare tumor, most commonly arising from the adrenal medulla. In clinical practice, it usually manifests with hypertension, which can be either constant or paroxysmal, meaning that you have a big bout, a big attack of hypertension. A bit less frequently, you can have Pheochromocytoma in other autonomous ganglia, either within the thoracic cavity or with the abdominal cavity, but remember, most commonly we see it in the adrenal gland. So let's check out the histology. The tumor is made up of larger cells with uniform vesicular nuclei with slightly rough chromatin. So the chromatin is a bit rough, like salt and pepper, but the nuclei are usually quite uniform. What is more interesting is the cytoplasm, which, as you can see, it's slightly eosinophilic and granular. These granules here, these granulations that you see, these are the granules which contain the good stuff, the vasoactive mediators, adrenaline and noradrenaline. So the tumor can release a lot of adrenaline and noradrenaline, for example, when you touch it during surgery, or if you provoke the tumor pharmacologically. For this reason, if you know that you're going to resect a pheochromocytoma, then you need to pre-medicate the patient to avoid a hypertensive crisis during anesthesia. That is not a good thing. A lot of adrenaline will be present also in the anesthesiologist and the surgeon, not only within the patient. So remember, the cells have a lot of secretory granules. This means that they are positive with neuroendocrine markers, chromogranin and synaptophysin. If we zoom out a little bit more, you can see that the cells are arranged into these islands, like this. Here's an island, here's an island. They are labeled with the German name Zellballen. It means balls of cells, so Zellballen with a Z. Balls of cells. But one thing that you can't really see is that in reality here there's a dual population of cells. There's the immediately obvious population of the big secretory cells, but you also have a smaller population of the so-called sustentacular cells. These stain with S100. I have a nice picture of S100 immunohistochemistry in my companion lecture. Feel free to check it out. So once again, recapitulation: rather monomorphic tumor cells arranged into balls of cells or Zellballen. They have granular cytoplasm and relatively uniform nuclei with salt and pepper type of chromatin. Whenever we are assessing whether this tumor is malignant, remember, every pheochromocytoma is potentially malignant. Then there are no really good histological features to tell us that. The only way you can determine that the tumor is malignant if it has metastasized. So these patients with these tumors, they need to be followed up complexly in order to figure out whether the tumor has metastasized or not. So that's all for pheochromocytoma. Let's move on to the next one, and that is ganglioneuroma. Most ganglioneuromas are benign tumors. They arise from the autonomic ganglia But you can see small ganglioneuromas also within the gastrointestinal tract, within the intestines or within the stomach. From time to time you see a polyp in the stomach or a polyp in the intestines. You take a biopsy of it and it's a surprise, a ganglioneuroma. It's just something fun to see as a pathologist, something different for a change. So let's check out the histology. In this case, we are going to have a standard ganglioneuroma from an autonomic ganglion. So it has a dual population. It's called ganglioneuroma, so it has a ganglio and a neuroma population. So let's check first the ganglion cells. These are just standard run-of-the-mill ganglion cells, the same that you see in autonomic ganglia. You see this ganglioneuroma, it recapitulates the architecture of autonomic ganglia quite well. And look here, we even have the lipofuscin pigment within the ganglion cells, so it's a beautiful case. Let's check out another ganglion cell. Once again, nice big with a big nucleus. Well, they are supposed to have the nucleus in the middle, so let's go back to our previous one. So once again, big vesicular nucleus, eosinophilic to basophilic. Well, this is more like basophilic cytoplasm and the lipofuscin. So this is a standard ganglion cell. And here we have these small flat nuclei. These are the so-called sustentacular cells. Sustentacular cells are like a sort of glial cells which support the ganglion. So they are surrounding this ganglion cell as well. They are S100 positive. These are the same cells that you see in Pheochromocytoma, remember? And if we zoom out a little, you see that here's the second component. The second component is made up of these delicate spindle cells with this very elongated and wavy nucleus. You see, here's the wave, nice and wavy. Let me find the nucleus which is a bit more wavy. This one is quite wavy as well here. Elongated wavy nucleus in delicate spindle cells within this very soft, very delicate matrix. So ganglioneuroma. This is quite easy to recognize. Spindle cells in a delicate matrix and ganglion cells, ganglioneuroma. Here this example has a lot of ganglion cells, so it's quite easy to recognize as such. Here are some more. Here is a nice group. This one also has a beautiful big nucleolus. This is a sign of just a very heavy metabolic activity and proteosynthetic activity. So let's move on to the next one. Schwannoma. It's also called neurinoma. Schwannoma is a tumor coming from the peripheric nerve sheath. It affects the peripheric nerves. Of course, we also have peripheric nerves within the cranium, so you can see it also on the acoustic nerve most typically. And bilateral schwannomas are a sign of neurofibromatosis type 2. Almost 100% certainty. You can say that the patient has a neurofibromatosis type 2 if they have bilateral schwannomas. Now let's check out the histologic picture. Here this schwannoma is made up of Anthony A areas almost exclusively. So we unfortunately don't have any Anthony B areas. At least I went through it and I couldn't see any with certainty. So this one has only Anthony A areas. I have a picture of Anthony B within my companion presentation. So what you get in schwannoma is this palisading of the nuclei. So this is a tumor consisting of spindle cells. Here you see the spindle cells with the elongated nucleus. All very small nuclei, maybe slightly hyperchromatic but not particularly atypical, and they palisade. It means that they are arranged parallel like the picket fence in front of the suburban American homes, the white picket fence. This is not white, this is purple. I guess it goes with the times, the color. So purple picket fence, and here you can see that there's a parallel arrangement of one row of nuclei and another row of nuclei, and in the middle you can see these fibers. This is the so-called Verrocay body, V-E-R-O-C-A epsilon, Verrocay. He used to be a big pathologist from South America, if I recall correctly, and he's the one who described it, one of the pioneers of modern pathology. So Verroque bodies, these are beautiful textbook example Verroque bodies. We are quite impressed if you manage to find one during the slide examination. So this is Schwannoma. Schwannomas are benign tumors. They can be bothersome if they are located in the wrong spot. For example, a schwannoma within the spinal canal can compress the spinal cord. Schwannoma of the acoustic nerve can also be quite bothersome if large enough. So this is how they cause trouble. Here we just jump back a little bit to the, I think, week 3 or week 4. Look at this pigment. Try to guess. This pigment is hemosiderin. So there was probably some kind of bleeding into this schwannoma. This is a focus of bleeding. Maybe there was some kind of trauma. Maybe the patient bumped the schwannoma with something. Well, if we zoom out, we see that this has a quite respectable size. Let's measure it. This 14 millimeters. So it's quite nice in size. So if this was on an exposed area, it could be traumatized. So this is a schwannoma. It's a benign tumor. It doesn't turn malignant. Let's move on to the next nerve sheath tumor. And this is a beautiful example of plexiform neurofibroma. Whenever you read that the patient has plexiform neurofibroma, you can be almost 100% sure that this patient has neurofibromatosis type 1. Plexiform neurofibromas are very annoying because they can grow huge, and they are very difficult to resect because they have unclear borders. We have a very good department of plastic surgery, so we get from time to time some very big excisions from patients with neurofibromatosis. You're going to see a few of them during your clinical practice there. If you're going to have a clinical practice at all, who knows with this COVID thing, how long the madness is going to continue. But I digress. Let's get to the slide. So here we have the epidermis. There's a bit of hyperpigmentation, probably induced by the tumor. So this was a brown and rough area. You can see that the surface of the epidermis is uneven. So this was quite rough and unpleasant to look at. And here we see that the dermis has expanded dramatically, and we see multiple fibers of something, multiple very thick fibers of something occupying a large part of the dermis. This is the so-called plexiform neurofibroma. So the plexiform neurofibroma is made up of these very big, very coarse fibers. It looks coarse, but it's allegedly very soft to the touch. It's like touching a sack of worms. That is how the feeling is described. I've never tried it myself. Maybe you will get the privilege to try it once. So it's soft but firm to the touch, like a sack of worms. If I zoom closer, you can see that it's made of spindled cells, which are quite uniform. They are quite uniform to the ganglioneuroma cells, so it's very similar to ganglioneuroma if you remove the ganglion cells. So the part with the spindle cells, with the wavy nucleus in the delicate matrix, this looks the same. It comes from the nerve sheath, and in the plexiform neurofibroma it's arranged into these very big, very coarse bundles. They all look the same. Spindle cells with the wavy nucleus in this delicate stroma. This one is a bit myxoid, so there's a bit of mucin accumulation. This could be Elschen blue positive in theory, but it means nothing for the diagnosis here. So plexiform neurofibromas are huge and very bothersome tumors which cause big cosmetic distress to the patient, and sometimes there are attempts at removing them, but they usually come back. So let's move on to the next one. Next one is granular cell tumor. This is probably the rarest of the peripheric nerve tumors that I talk about today. This one can be seen in the gastrointestinal tract, especially in the esophagus. You can also see it in the tongue, but this one is from the skin. This one is quite large. It usually tends to be smaller. So here you see epidermis, nice epidermis. Here we have some sebaceous glands. This is connected to a hair follicle. And then here in the middle we have this big lesion. Let's start from the bottom. This gets even into the subcutis, but it shouldn't cause any concern. We zoom closer and we see that it's made up of very uniform cells with very small and regular nuclei, with fine chromatin and a small nucleolus. And this tumor has a very ample cytoplasm which contains granules. These are some kind of secretory granules. They don't contain adrenaline and non-adrenaline like Pheochromocytoma. Remember, this is not a Pheochromocytoma, but it has a very similar cytoplasm, quite ample. But this tumor is totally different. It doesn't secrete anything. It doesn't cause any paraneoplastic syndromes like Pheochromocytoma. But it can cause a very interesting phenomenon, which can be quite troublesome in the esophagus. So if we go up and up, we see that here the epidermis is very strange. You see here this keratinization. So the epidermis has enlarged a lot. It has become, look, this is how thick the normal epidermis is. And this is how thick the epidermis is above the granular cell tumor. So this granular cell tumor has caused reactive changes within the epidermis. This is called pseudoepitheliomatous hyperplasia. Pseudoepitheliomatous hyperplasia. This is hyperplasia of the epidermis. So what's the problem here? Here there's no problem, but the problem is, for example, in the esophagus, because this in endoscopy it can imitate squamous cell carcinoma macroscopically, and if you don't take a sample which is deep enough, so if you take a sample only from the surface, then you will get only squamous epithelium. You need to take a deeper sample in order to get to the granular cell tumor. So the first groups of granular cell tumor are here. They are quite deep. Let's measure the depth. So they are 2 millimeters deep. So you need to take quite a deep biopsy to find them. So this can be a pitfall in esophageal tumors, for example. The pathologist can also be fooled by this hyperplastic epithelium and say that this is well differentiated squamous cell carcinoma. So this is the only pitfall that I can think. Other than that, it's a mostly benign tumor. It's completely healed when removed. I think here they went all out. They went very deep into the subcutis and they gave ample margins to it. Maybe they thought it was a melanoma, who knows? I mean, this is quite big and not very nice looking, probably clinically. But granular cell tumor is almost always benign. Remember the tumor cells with the granular cytoplasm and hyperplastic reaction in the epidermis. That's the pitfall. So let's move on to the next one. Now we jump to the meninges. This is a very nice slide of meningioma. Meningioma is one of the most frequent primary CNS tumors that you can encounter. And it's almost always benign. There are some cases of atypical and anaplastic meningioma, but those are rare. So most meningiomas are expected to be benign. Let's check it out. So most meningiomas are made of spindle cells. This is another spindle cell tumor. So we have, for example, Schwannoma in the differential diagnosis. But there are some differences. For example, that in many meningiomas you can get the so-called psammoma bodies. These are concentric calcifications. They are of degenerative origin, so there's some kind of degenerative process within the meningioma, and it forms whorls which calcify. You see here the whirling of the epithelium, like a whirlpool around it. So this is a psammoma body. It's basophilic because it's calcified. This helps us because you can see it also on a CT scan. So this could be another clue for it being meningioma, that you see the psammoma bodies on a CT scan. Spindle cell tumors, all the spindle cells are uniform, no obvious nuclear atypia. This is meningioma. They are quite easy to remove in most cases, you just peel them out. They just compress the brain, but they usually don't invade into it if they are benign. Higher grade meningiomas can also grow invasively and be bothersome this way. But in most cases they are easily removed. The majority of cases probably never become symptomatic for the patient, so not every case is treated. We often see it during autopsy as a small surprise. So recognize the psammoma bodies, there are multiple, this should make it quite easy. So let's move on to CNS neoplasms. So most neoplasms in the central nervous system in adults arise from astrocytes. We have at least a dozen different types of astrocytic tumors. They can have different WHO grades. Please remember there are 4 WHO grades, grade 1 to 4. Astrocytoma, also called diffuse astrocytoma, is a grade 2 astrocytoma. Let's check it out in histology. Here we have a big tumor. This was probably an autopsy finding because everything is tumor here, everything is neoplastic. So I will just describe it briefly. So it consists of a single monomorphic population of glial cells. There's only slight atypia. This is a lymphocyte, this is a neoplastic glial cells. So all these slightly atypical cells, they are all glial cells with astrocytic differentiation. WHO grade 2 tumor. These cells are positive with GFAP or glial fibrillary acidic protein. That's the marker that we use. So in general, tumors with grade 2 astrocytoma or diffuse astrocytoma, they survive for a long time, but the problem is that this tumor is diffuse, that's what it's called, and it grows diffusely with very poorly circumscribed borders. So it's quite difficult to remove. And these patients will have relapses, and if they are really unlucky, then this grade 2 astrocytoma can progress into grade 3 anaplastic astrocytoma or even into glioblastoma, which is a grade 4 tumor. So the prognosis depends a lot on the luck the patient has and on the effectiveness of the surgery and irradiation eventually. So this has been astrocytoma. Let's move on to the ugly one, glioblastoma. Glioblastoma multiforme is the most common primary CNS neoplasm in adults. It's a WHO grade 4 neoplasm. It's highly aggressive with very poor prognosis. Here at our hospital, we get operative samples almost exclusively from glioblastomas. So this is the only tumor that we know very well to diagnose here, but it's also the most common one. So let's check it out in histology. Here I have some helping aids for me to find. So first we zoom in. This is a highly cellular tumor. This example is a bit less pleomorphic, but the degree of nuclear atypia is variable. You see here that the cells have a very dense chromatin. Some of them are a bit more spindled, others are a bit more rounded, but they have very significant hyperchromasia. So at first glance it doesn't differ a lot from the astrocytoma, but there are basically 2 key features that help us differentiate. You need to learn these features. So first feature is the geographic necrosis and palisading of the nuclei of the glioblastoma cells around it. So here's an area of coagulative necrosis. You see here the eosinophilic stuff. These are dead glioblastoma cells and some fibrin exudate. So it's geographic because it looks like a country or a continent. So if something is like this big irregular shape, we use the term geographic. Geographic means that it's map-like Looks like a country on a map. Well, this could be maybe Chile, as it's long. So Chile. So geographic necrosis with palisading around it. It means that there's condensation of the nuclei of glioblastoma around it. This is the first feature, the necrosis. And the second feature is the microvascular proliferation. This means that in glioblastoma you get newly formed blood vessels in large numbers. Here's a beautiful mitosis. So you get in large numbers newly formed blood vessels. You don't have this in astrocytomas. So newly formed blood vessels in glioblastoma. These are the two trademark features. So it's a triad of nuclear atypia and hypercellularity plus this strange necrosis with nuclear palisading plus the microvascular proliferations. These are the three features that give you the diagnosis of glioblastoma. Finally, another important capital in the CNS neoplasms are secondary CNS neoplasms. Remember, in absolute numbers, you have more metastases than you have primary malignancies in adults, especially. So there are more metastases to the brain than there are glioblastomas. It's very common to get brain metastases in advanced cancer, especially carcinomas of the lung, colon, prostate, kidney, breast, and so on. So some cancers are a bit more prone to causing metastases than others. So here's the first thing that can happen is the so-called carcinosis of the meninges. In this case, you don't get a completely obvious like a round area of metastasis, but you get diffuse infiltration of the meninges. So here's the gyrus, here's the sulcus, and here in the subarachnoidal space you can immediately see that something is going on. There's something which shouldn't be there. This is a normal subarachnoidal space here, this is normal, and this is abnormal. Even from this magnification it's obvious that these are glands. Here is some mucin production, but most of them are just glands of irregular shape with epithelium, with spectacular nuclear atypias, with bizarre pleomorphism. Here you see that every nucleus is of different shapes and sizes. So this is adenocarcinoma. This is a metastasis of adenocarcinoma which has affected the meninges. If I move on to this area, I can see that it's also in the Virchow-Robin spaces. It has gotten deep into the brain. Through the Virchow-Robin spaces, it's spreading alongside the blood vessels. So this patient died of this very advanced cancer. If this were a lady, then I would think of breast cancer, but this could also be lung cancer. I don't know, honestly. It's difficult to tell from the morphology, but lung cancer or breast cancer are in the top options for this to happen. These patients, they have very poor prognosis, survive just for a few months with this. They are sometimes given chemotherapy injected directly into their ventricular system. And unfortunately, this is a sign of very progressed cancer. Let's move on to another metastasis. Another tumor which can metastasize to the brain is melanoma. I have already shown you one metastasis of melanoma, I think in the second or third week. So let's check out another one, just to be sure. So melanomas can metastasize anywhere. They metastasize to the brain as well. A good clue when you look at the metastasis of melanoma is that in many cases there is some pigment formation, not in every case, but in many cases, and in this case we have a lot of pigment. This is melanin. So on macroscopy this metastasis is going to be brown. Here we have the cerebellum, and here we have just the cortex. So this is a sulcus. So this has metastasized to the cortex. And this also has metastasized to the cortex of the cerebellum. Let's go closer. Big ugly cells, mostly spindle-shaped, with a typical nucleus for melanoma. So melanoma usually has a vesicular chromatin and a big nucleolus, as you can see here. So this is the typical look of melanoma. This cell is very typical. It couldn't deny being a melanoma. So vesicular nucleus with a big nucleolus. So this is standard for melanoma. And also look at all this pigment. It has produced a lot of melanin, so this is undeniably melanoma, no questions asked. Well, the only question is where's the primary in some cases. Melanoma is very unpredictable in its behavior. It can metastasize anywhere. Remember, it can metastasize after 15 years of being treated and completely cured, allegedly. But melanoma can come back anytime. It's quite unpredictable. And for the final slide, we have one more metastasis to the brain. And this is a metastasis of adenocarcinoma of the lung. So lung cancer can metastasize to the brain relatively early or relatively soon during its clinical course. So patients with lung cancer are at increased risk of early metastasis to the brain. And here we have an unfortunate case. This was a relatively young lady, smoker, who had adenocarcinoma, and it has metastasized to the brain. Here we see the adenocarcinoma glands. So irregular glands lined by epithelium with obvious cytological atypia, with differently sized and shaped nuclei. Some of them are a bit more vesicular, others have a bit more rough, dense chromatin. And the metastasis is also partially necrotic, so this was a big metastasis, big like this. So it was a few centimeters across, much larger than what you see here. So this is an unfortunate finding, but typical for lung cancer. So that's all for this lecture, and thank you for your attention.